Hey everyone, this is Rona again, Internal Medicine PGY2 at Walter Reed with another shelf review video. And today I'll be discussing some additional common infections that you might see on the boards, with a particular focus on patients who are immunocompromised. So starting off with some HIV related questions, first is which medication is used for prophylaxis for both PCP pneumonia and toxoplasmosis in HIV patients? So the answer for this one is trimethoprim sulfamethoxazole. You might also see this listed as TMP SMX, and in the hospital you may hear it referred to as Bactrim. So the big number to remember is 100 for both. If there are some nuances to that, if they give you an HIV viral load that's positive and the CD4 is less than 200, you'd also start PCP prophylaxis. And for toxoplasmosis, you would start it if the CD4 is less than 100 and you have positive serologies. But I think for the purpose of your exam, that 100 number is the big thing to remember. And when would you start prophylaxis for Mycobacterium avian complex, or MAC? So this is the number to remember for this one is a CD4 of less than 50. But the main thing to remember is that if you have an option to pick starting antiretroviral therapy, that's probably going to be the correct answer on your exam. There are some other smaller scenarios where they probably won't test you, where if you are viremic despite starting antiretroviral therapy, or you have no options for full suppression. And what do you use for MAC prophylaxis? So the answer for this one is azithromycin or clarithromycin. And just some additional information on these opportunistic infections and prophylaxis. Again, if you see that starting antiretroviral therapy is an option, that is probably the answer they're trying to get you to pick. If for PCP you are on prophylaxis, but they also start antiretroviral therapy and the CD4 is at least 200 for at least 3 months, then you can actually discontinue the prophylaxis. So the 200 and the 3 months are going to be the numbers to remember. Similarly, toxoplasmosis is easy to remember because you can also discontinue it if the CD4 is at least 200 for at least 3 months. For this one, you also want to make sure that their viral load is suppressed so it's undetectable. And for MAC, the main thing I want to highlight is that prophylaxis is no longer recommended in those who start antiretroviral therapy right away. So again, if you have the option of picking antiretroviral therapy, that is probably the correct choice. And you technically should also be ruling out disseminated MAC before you start them on prophylaxis. So the next one is, would you expect a fast or slow onset for PCP pneumonia? And this is actually a reminder from a previous video. You would expect slower onset, so less acute. And what would you expect to see on imaging? So this is again a reminder from our previous video, but you're seeing these diffuse bilateral infiltrates. So it's not going to be a nice lobar consolidation like you would expect for a bacterial pneumonia. And how do you diagnose PCP pneumonia? So the silver stain is going to be the big buzzword. And then what do you use to treat PCP pneumonia? So this is easy to remember because it's the same medication you use for prophylaxis, which is going to be your Bactrim or your TMP SMX. And when do you add steroids for PCP pneumonia? So those of you who met with me in person, you know that there are certain criteria they like to test you on, and the options will be things like supportive care, make sure they're ventilating well, and then steroids will be an option. And they're trying to get you to think about, do you know the indications for starting steroids for someone who has PCP pneumonia? And that's if their A gradient is at least 35 or their arterial PO2 is less than 70. In the real world, if someone is coming into the ICU very sick with concern for PCP pneumonia, you'll often see them started on steroids right away. So that's something that you might see that's a little different from what you might see on your exam. And now going on to our next opportunistic infection, what would you expect to see for toxoplasmosis on CNS imaging? So these are going to be your multiple ring-enhancing lesions, which we see here. And what else is on your differential for CNS conditions in immunocompromised patients? So a couple of things they like to test you on: lymphoma, things like primary CNS lymphoma, progressive multifocal leukoencephalopathy. You can have HIV-associated neurocognitive dysfunction, and then cryptococcus. And there are certain viruses that are very high yield for these conditions. So if they're trying to get you to think about primary CNS lymphoma, there's a very high yield virus. Do you know which virus that is? So that's your EBV. So if they tell you that there's evidence of EBV DNA in the cerebral spinal fluid, really try to think about primary CNS lymphoma. And how would you treat primary CNS lymphoma? So this is going to be methotrexate, but my UWorld notes are really emphasizing that a brain biopsy should be obtained before you start this agent. And just to show you what CNS lymphoma looks like, you can see it looks pretty different from those CNS toxo images we saw earlier. So that toxoplasmosis was the multiple ring enhancing lesions, but primary CNS lymphoma will most commonly show up as a solitary, bright, contrast enhancing mass, and it can cross the corpus callosum. And now let's try to think about a different condition, or PML. So we just talked about how EBV is associated with primary CNS lymphoma. There's a different virus that's associated with PML. So this is going to be your JC virus, and there's also a very high yield medication that's associated with PML. And this one is natalizumab, which is a medication used to treat multiple sclerosis. So especially if the question tells you that the patient has MS, keep this diagnosis in the back of your mind. And how do you treat patients with PML? So the key point is to treat the immunosuppression, treat the HIV, start them on antiretroviral therapy. And this is an example of a real case of a patient with HIV who came in with 2 weeks of a headache and progressive aphasia. There were prominent white matter lesions that you're seeing on imaging, and this is a demyelinating disease. And on his workup, he had positive JC virus DNA on his PCR, and he was treated by starting antiretroviral therapy, again, treating that immunosuppression. And finally, let's go into cryptococcus, which your world is really emphasizing as the most common cause of meningitis in AIDS patients. Which CD4 count would you get especially worried? So we mentioned this is especially prevalent in AIDS patients, and most with cryptococcus meningitis will have a CD4 less than 100. And what would you expect on your CSF fluid in terms of labs like glucose and leukocytes? And they love to test on these CSF fluid differences for the different agents of meningitis, so make sure to review this before your test. But you'll see things like high protein in leukocytes, mostly lymphocytes, and then unlike bacterial infections, the glucose can be normal. They might also tell you that there's evidence of yeast on Gram-Steiner culture. And which stain is used to visualize cryptococcus? So that's your India ink stain. And this is an example of what you might see. This is a very classic example of this encapsulated yeast. So with this India ink stain, you're going to see these yeast with halos. And how do you treat cryptococcus meningitis? So this is a more complicated regimen, and the way I was taught to think of it is like you're trying to treat an oncology patient with chemotherapy. So essentially, you'll need a minimum of at least 2 weeks of an induction period with amphotericin B and flucytosine, and then you'll need to have many different weeks of different doses of fluconazole. So the way they might test you is either picking that induction agent, or they'll tell you the patient has finished that induction agent. What do you do next? And the answer is they're trying to get you to pick fluconazole. And what would you expect the opening pressure to be on your lumbar puncture? Would you expect it to be low, normal, or high? So the LP, you would expect the opening pressure to be elevated. So some patients may actually need therapeutic lumbar punctures or drain placement. Now let's go into some buzzwords for diarrhea in immunocompromised patients. So what if they're specifying that it's bloody and the CD4 is less than 50? So they're trying to get you to think about CMV. And what if it's severe watery diarrhea? So this one is your cryptosporidium. And what if they especially emphasize a high fever, like more than 39 degrees Celsius, and again, CD4 is less than 50? So this one is your MAC. And there's some buzzwords for esophagitis as well, so feel free to pause and test yourself as you go. But what if they have some substernal burning and oral thrush, their CD4 is less than 100? So this one is, they're trying to get you to think about Candida albicans, especially with that oral thrush. And how would you treat this patient? So the answer is oral fluconazole, but if they're not responsive or you're not seeing any evidence of oral thrush, they do want you to think about getting an endoscopy for further diagnosis. So what if you do get an endoscopy and you notice that there are these large linear ulcers and the biopsy is showing intracellular inclusions? So this is the buzzword for CMV esophagitis, and remember, CMV was also a buzzword for diarrhea in our immunocompromised patients, so it's a virus that can affect many different organs. And what if they specify that there are these small, round oval, volcano-like lesions with multinucleated giant cells? So this is going to be your buzzword for HSV esophagitis. So going into cryptosporidium, again, remembering the buzzword for this was that severe watery diarrhea. They may give you some swimming pool or animal exposure history. And what is the treatment for this? So it's supportive and making sure that they're on antiretroviral therapy. And would you expect the bowel movements to be bloody? So no, and that one is going to be, again, remembering a buzzword for your CMV colitis. And would you expect a high fever? So again, no, that's going to be more of a buzzword for your MAC infection. And CMV, again, very important affects multiple organs. It can affect the eyes, which is a high buzzword. You might see something on exam like your retinitis with the fluffy yellow and white infiltrates. Um, Remembering that diarrhea buzzword was that bloody diarrhea, especially if the CD4 is less than 50. It, and then what would you expect if you took a biopsy of an affected organ? What would you expect the cells to look like? So this is going to be your intracellular inclusions. They may also give you that owl's eye buzzword. And this is an example of what it actually looks like on the slide. So you're seeing those intracellular inclusions, and you can see why they might give you that owl's eye buzzword. And how do you treat a patient with CMV infection? So this is going to be your IV ganciclovir. And just for some time-space learning, what would you expect to see with esophagitis? And these are your large linear ulcers. And then thinking about the other esophagitis buzzword, again, if it's a volcano-like lesion, that's pointing more towards HSV esophagitis. So for HSV esophagitis, what types of cells would you expect to see on biopsy? These are your multinucleated giant cells. And then HSV, again, can also affect lots of different organs. So for encephalitis, there's a particular part of the brain which is frequently involved in high yield. This is going to be your temporal lobe. And how do you treat HSV encephalitis? So this is your IV acyclovir, and you should be starting this while you're waiting for your results if there is a high enough suspicion. And how do you diagnose HSV encephalitis? So PCR of the DNA and the CSF is going to be highly specific and sensitive. And what would you expect to see on a slit lamp exam for HSV keratitis? So if you're worried about eye involvement. So these are going to be your linear branching ulcers or your dendritic ulcers. And this is just an example of that slit lamp exam for someone with HSV keratitis, and you're seeing those nice linear branching ulcers. And what if instead you performed a slit lamp exam and it's saying that there are multiple ulcers with feathery margins? So this is pointing more towards Candida keratitis. And that's all I had for this review video. I hope it was helpful. I would love to, again, hear your feedback. And for some of you, I'm looking forward to meeting you and working with you in person.